Good morning. How's everybody? All right. So I didn't get to do this yesterday. EMS, paramedics, EMTs. All right. Emergency department nurses. I am actually absolutely coming after y'all during this talk. So hang on. And physicians, floor nurses, ICU nurses. Fantastic. Peds hospital people. 0. Couple. 2. No, you sort of raised your hand there. I'm going to ask you a question now. Good. All right. Well, good morning. Thank you again for having me back. I really appreciate it. This is important. It's important. I said it yesterday. If you have a healthy 1-year-old, the number one thing that's going to take them from you until they're age 44 is an injury. Between 1 and 14, if you add up all the causes of death, trauma's half, everything else is half. It's the most important public health issue facing pediatric patients in Mississippi, in Arkansas, in the United States, worldwide. As we make great strides with HIV, AIDS, and diarrheal disease worldwide, trauma is going to end up being the number one killer of children worldwide. So it's important. It's important. And that's really the question is, are we doing our best? Are we doing the things that are evidence-based to try to improve outcome when we encounter them? This is Arkansas-specific data, and this is Arkansas metric against the rest of the country. And we suffer a little bit. We have a little bit of higher teen suicide rate in Arkansas than the rest of the country. We're addressing that. But our unintentional injury, that first bar, you may not be able to see the axis there, but the first bar shows that our unintentional injury death rate is almost twice that of the rest of the country. When I started in Arkansas with the system in 2009, if a child that was in a car crash, their chances of dying were 3 times the national average dying in a car wreck. And I told you a little bit about why. We'll cover some more of that today, but I'll break it down. And again, I shared this story yesterday. I got to Children's Hospital and they said, we don't need you. We're doing fine. And it actually was true. The Children's Hospital, the things that we did in the tertiary care center ended up making very little difference in the overall mortality of pediatric patients. Where it really mattered is where you work, in the pre-hospital arena, in the community hospitals, in the level 3s and the level 4s, and in the transfer process. That's actually where our morbidity and our mortality was occurring, or in our opportunities to salvage and save were occurring. And it's not a Mississippi issue or an Arkansas issue. This is a national issue. Most medics don't get to intubate an infant very frequently. Busy urban areas, you intubate about 1.5 times a year. So let me tell you something. It works the other way around. We live, my hospital lives in sort of a rough neighborhood, and so every once in a while, an adult will just stumble into the Children's Hospital. You're talking about chaos. It is chaotic. And I go down, and at this point, I did adult trauma for a long time, but at this point, some 70-year-old comes in to my Children's Hospital. I'm scared. I don't mind saying it. I'm a little scared of them. I understand how it works in reverse. So we don't get a lot of opportunity to practice. We're out of our comfort zone. We're out of our skill set a little bit, and so things don't necessarily go as well. In our state, though, when we did our preventable mortality, these were the things that were killing kids. These were the opportunities that we had to salvage a kid or save a kid, and they're not the fancy things done at the Children's Hospital. They really were, did you put an airway in when an airway was necessary? Did you put a proper airway in? Did you decompress a chest when it was time to decompress a chest? Did you get IV access and give fluid if it was needed? Did you give too much fluid if it wasn't needed? Those were the causes of our preventable mortality in pediatric patients 150 miles north of here. Probably not much different than right here. Those were our causes. So you have to have a triage system that speaks specifically to children. There should be different activation criteria in your pre-hospital arena and in your hospital arena for an activation of a pediatric patient based on differences in physiology. And we're going to talk about all of that. Getting them to getting the ones that really need it to a pediatric trauma center is important. Traumatic brain injury is the #1 cause of death in pediatric patients, and 3 things have been shown to improve outcome. Just 3. Don't let them be hypoxic, don't let them be hypotensive, and treatment at a pediatric trauma center. Those are the 3 things. Those are the things we can do to improve outcome in a pediatric patient. This is the way they must look to you. That's the same way the 80-year-old looks to me. All right? That's my daughter, and that is the way she looked for about the first, between about 5 and 20, she looked that way. It's gotten better. It's gotten better. For those of you that had girls, it gets better. They turn into humans about 21. The boys don't do that. Pre-hospital. So as I think about how to maybe change my activation criteria, my sense of priority, these are the things that matter. These are the things that matter. The pediatric patient, I'm going to show you some slides about this later. The pediatric patient that is hypotensive, even mildly hypotensive, is way down the power curve. That is in trouble. You're in trouble if you get a pediatric patient who is hypotensive. Now, quick, what's hypotension? I got a 2-year-old coming in, lights and sirens. Come on, what's normal blood pressure supposed to be? I don't know. I don't know. I work in a pediatric trauma center. I see 1,600, I admit 1,600 pediatric trauma patients a year. I don't know. And when the lights and sirens are going off and everybody's looking at me, I don't know. We write it on a poster and it sits in our wall in our trauma bay, what normal vital signs are. All right? That's what we do in the children's hospital. That's surely what you should do in your hospital where you don't see that many peds patients and you don't see them sick very frequently. Respiratory compromise, tachycardia, or tachypnea is a common compensatory mechanism for shock and a very important sign. Impaired mental status. Now, this one's a little misleading. I will tell you that it's not uncommon at all. You take a kid from mom and you strap them down, you put them in the back of the ambulance, so they scream and scream, and then what do? They get quiet and they get a little regressive. And that's normal, but you've got to activate on that. And so I spent the early part of my career going, God, I mean, the kid's just, and that's just a kid. That's just a kid. And they're not obtunded, they're not declining. But you can't know that in the pre-hospital arena, and you should activate on it, and we should activate in the hospital on it, and we're going to over-triage. Big deal. That's what we're supposed to do. That's what we're supposed to do. So those 3 things are really important. And if you want to think about it sort of pictorially, the assessment triangle developed by a guy named Bob Wiki really does work. If you have evidence that they're in shock and you can provide that to the hospital and your call in, I believe they're in shock because they have poor capillary refill, their heart rate is high, they're tachypnic, their blood pressures are low. I believe they are in shock. Then that is the highest level activation. They're having respiratory distress. They're breathing too fast, too slow. It's labored. It's uneven. That's respiratory distress. We're going to activate on that. Their mental status is declined, be it from a regressive behavior or a head injury, which is the most common reason that we're going to activate on that. All right? So that assessment triangle is a great way to think about it. It's a great way to think about it. If any of those are deranged, we're going to treat them at a high acuity. So what do I do? Now, I work in a level 3. I work in a level 4. I don't see that many kids. I sure don't see that many that are really sick. What do I do now? Well, it is good to go to the classes. I think the classes help. I think PALS help us with some baseline stuff. I think you'll get lectures like this. All those things help. What I think helps the most is consistency, checklists, and some tools. So I got a 2-year-old. My friends, the medics, called in. 2-year-old struck by a car. They believe he looks bad. Doc, I think he's in shock. And he's got a declining mental status. All right? Again, I'll put you on. What's a normal blood pressure? What's a normal blood pressure for this 2-year-old? I don't know. I think he's going to need to be intubated. What size ET tube? What size ET tube do we use for a 2-year-old? What size ET tube do you use for a 2-year-old? Anybody? You know what my answer to that is? Whatever that Broslow tape tells me. I don't know. I don't know. I'm telling you. But we use the Broslow tape, 1,600 trauma admissions a year, about 4,000 trauma evaluations in the emergency department. We use the Broslow every single time. You should not make this mistake. And it'll tell you. It'll tell you what tube you use. It'll tell you what blood pressure is. It'll tell you what the dose of etomidate is. It'll tell you all that. It should be used in the pre-hospital arena. And Broslow's a certain brand. You can make up your own. I saw a place the other day that had a Craftsman, tool cart, and they color-coded it. Perfectly fine. But during the code of a 2-year-old that you don't see a lot of those is not the time to try to guess. Use the Broslow. Use it and get it right. Use checklists for those things. Drill on this. Bring a 2-year-old into your trauma bay. Bring a dummy into your trauma bay and run through this activation and run through these things. And do we have the equipment? Do we have the processes in place? Do we have the people? Can we summon them if we need to? And then the biggest thing is phone a friend. Phone a friend. I am a click on a mouse away from your trauma bay. If you've got a Tandberg machine, if you've got a telemedicine machine, I am a click on a phone away from being in your trauma bay and helping you with the resuscitation. I'm positive that the Children's Hospital in Jackson's, the one in Mobile, all of those will do exactly the same. Get some help. Get some help with them. It really does matter. I love this picture. I love this picture. This picture is very meaningful to me. It is my about 31-year-old wife who was pregnant with our second son, our then 1-year-old son, and my 83-year-old grandmother. All right. What are the priorities of the trauma resuscitation for all 3 of those people? Exactly the same. Exactly the same. She's just a pregnant adult. He's just a little adult. She's just an old adult. They're all the same. It is control of active bleeding, airway, breathing, circulation. It is the same. And if you violate that, you will make a mistake. On any one of those 3 patients, if you violate that, you will make a mistake. But every one of those patients have unique anatomy and physiology that you got to know if you're going to do a good job. You know that if that pregnant woman comes in and she's hypotensive, you need to roll her on her side because her gravid uterus is sitting on her vena cava. You know that if you overextend that 83-year-old's neck with your intubation, that you're going to cause a problem. You should know that if you push the ET tube down, you put a 4.0 ET tube down in that 1-year-old, and you push it down to 20, that he's going to be right main stem intubated. You've got to understand the subtleties of the anatomy and physiology that make their care different, but the priorities are the same. It's actually not those differences where we get in trouble. It's not the fancy things that we do for peds. It's not putting the ET tube in. It's not decompressing the chest when you knew that was the right thing to do. This girl sneaks out of school. I'm in Houston, Texas. This girl sneaks out of school with her friends, finds a gun in somebody's house. Entrance is just to the right of the sternum. Bullets in her left scapula. It's gone across her mediastinum, through her pulmonary hilum. She is dying. She's hypotensive. She's dying. What does she need? What is her priority of management? Airway. Second, decompression of her chest. That's how you save her life. That's how you save her life. It doesn't matter that she's a pediatric patient. This is a patient we'd operated on and had an exuberant fluid resuscitation. And his belly's big, and he's not breathing well. He's not making urine. He's hypotensive. You could bounce a quarter off his belly. What does he need? A decompressive laparotomy. He's got compartment syndrome. Absolutely no different between those two. It's pulling the trigger that matters. This kid crashes on an ATV, got active bleeding from a leg that's dysvascular. What does he need in the field? A tourniquet. Direct pressure. C, A, B, C. If you make a mistake with that because he's a kid, if you forget those things, if you don't do them because there's something special about being a kid, he dies. He dies. He doesn't have a shot. He doesn't have a shot. So let's go through it, let's go through those, that CABC then. The first thing is, you get a ring down from EMS or you get a call to a scene, and what do you expect? The 2-year-old's been struck by a car. I got struck by a car. Where are my injuries? They're here, right? Their femur, their pelvis, maybe chest. Those are the anticipated injuries in an adult struck by a car. What's the anticipated injury of the 2-year-old struck by a car? Head, chest, and then the transfer of energy. I don't know how much the damn car weighed, but it weighed a lot. And it hit me, and all the force is transmitted here, right? And it's pretty focal. You hit the 2-year-old, this big, and the whole force is transmitted everywhere. So the incidence of multiple injuries, much higher in the pediatric patient, because the same force has been applied, but it's not focal, it's transmitted everywhere. So I anticipate more, I'm worried about more. Head is probably going to be my most common. So already I'm starting to think about how I'm going to resuscitate, what my likely injuries are, what equipment I need. I'm going to need to intubate this kid. The adult, unlikely. Kid, probably. How am I going to get fluids in? Are they going to lose heat quickly? Absolutely. All right, so the first is airway. Airway. Most common reason that kids arrest is loss of airway. If in doubt, provide an airway. Provide an airway. Do you have a common resuscitation cocktail for pediatric patients? If not, you should. Do you have a rescue airway for the pediatric patient when you can't intubate? If not, you should. Are you going to be able to intubate with a Mac blade? No way. In the young kid, do I have a small Miller? A Miller 0 or 1 or a Wist nipple? That's what I need to intubate with. What size tube? Come on. Whatever the Broslow says. That's right. That's the answer. Whatever the Broslow says is what we're going to do. And one size above that and one size below that. So there are the things. ATLS told us to use uncuffed ET tubes because it caused problems in the pediatric patient. Let me give you a scenario. I don't intubate patients much. If I'm called on to intubate a patient, I'm going to put the Miller tube blade in and I'm going to lift. And if God himself touches me and I see the chords, angels sing, I look, I go, oh, and what am I going to put through those chords? Well, I'm going to probably put something too small because I don't want to come back here. Like I'm scared. I don't want to come back and put something else. So I put something that's a little small. Then I put it in and I start bagging and it's uncuffed. What happens? Leak. So I'm not effectively ventilating. What's the number one injury in the pediatric patient? Head. What is the prime determinant of cerebral blood flow and swelling of the head? The entitled CO2. So now I've hurt the kids, I've made the head injury worse because I've driven up the entitled CO2 because I've put the wrong size ET tube in and I put an uncuffed tube in because that's what our service bought. That's all I got in the truck. That's all I've got in my Broslow bag there because we bought them 7 years ago and we haven't used them since. If I've used a cuffed tube, I put a little 1/4 cc of air in there, the leak stops. Peds Hospital will change it out later. I can ventilate now, I can oxygenate. I'm forgiven of my sin.